In this video, we are going to discuss about a very important, rather the most important acquired heart disease seen in children, that is the rheumatic heart disease. So there is an entity called acute rheumatic fever, and the heart disease that is seen accompanying that is, or a part of that illness, is called the rheumatic heart disease. So this rheumatic heart disease is in fact the most common acquired heart disease in children in developing countries like India. Okay, so most common acquired heart disease in children of developing countries or in children of India is rheumatic heart disease or RHD. Okay. Now this rheumatic heart disease is strongly linked with an antecedent streptococcal infection. Mainly streptococcal, sore throat caused by group A streptococcus or pharyngitis caused by group A streptococcus. Okay. So, RHD or acute rheumatic fever has been strongly linked with antecedent group A streptococcal infection, mainly pharyngitis. Okay. Group A streptococcal pharyngitis. Okay. Particularly, certain strains of group A streptococcus are notorious in predisposing to rheumatic fever. So, the strains which are notorious are M1, 3, 5, 6, 18 and 29. These are the ones that are most commonly responsible or most commonly linked to rheumatic heart disease. Okay. So, you may get a history of sore throat few weeks preceding the illness of acute rheumatic fever. Right? Now, the pathogenesis is immune mediated. Okay, the pathogenesis is immune mediated and molecular mimicry is believed to play a strong role. Okay, that means the group A, the antigens on the group A streptococcus antigen. So, group A streptococcus antigens resemble some of the antigens on the cardiac tissue. So, that is why if antibodies are formed against group A streptococcus, they also cross-reactive. They also cross-react with the cardiac tissue and cause carditis and other manifestations, joint involvement and so on. Right? So, there is no single sign or symptom or no single investigation which will give you the diagnosis. So, that is why there has been a need of a diagnostic criteria for this, which is a conglomerate of some clinical features and some investigations. Okay. So, very important for you from rheumatic fever is the modified Duckett-Jones criteria. Okay. Modified Jones criteria. Okay. So, the modified Jones criteria, the Jones criteria for rheumatic fever were first published in 1944 and there have been repeated modifications of this criteria. The latest one is the 2015 modification of the Jones criteria. Okay. Now let us see what this criteria says and what are the latest modifications in this criteria. So in the modified Jones criteria there are some major criteria and some minor criteria. But recently in the 2015 modification, they have been, the entire population has been divided into low risk population and a moderate to high risk population. And there is a slight difference in the criteria between these two populations. Okay. So there is a low risk population and there is a moderate to high risk population. Okay. Moderate to high risk population. So, this low risk population has an incidence of rheumatic fever. So, the incidence of rheumatic fever is less than 2 per 1 lakh school going children. Okay. So, that is the definition of low risk population. Right. And the RHD, rheumatic heart disease prevalence in this population, in the low risk population, the RHD prevalence is less than 1 per 1000 population. Okay. While in the moderate to high risk category, the incidence of rheumatic fever is more than 2 per 1 lakh school going children. and the RHD prevalence is again more than 1 per 1000 population. Okay. So this has been a latest addition in 2015 that they have divided the entire world's population into these two categories. Okay. So that is one modification in that latest criteria. Now let us see what these criteria are. So there are some major criteria, some minor criteria and an essential criteria. Okay. So the major criteria are, one is carditis. So carditis, now previously only clinical carditis was included in the modified Jones criteria. But as per the latest criteria, clinical as well as subclinical, that means just the echocardiographic evidence of carditis, if it is there, say mitral regurgitation or any other thing that is specified there. So if that is there, then also we take it as carditis. Even though there is no murmur, no congestive heart failure, no other clinical features of carditis, still we take the echocardiographic evidence, or subclinical carditis also is now included as a part of this criteria. Okay. So carditis, clinical or subclinical. So this carditis, subclinical carditis is again a latest addition in the 2015 criteria. Okay. Then you have arthritis. Now in this arthritis, there is again a slight difference in the 2015 criteria. So the 2015 criteria says that for low risk population, the definition of arthritis remains polyarthritis. Migratory polyarthritis, which is classically seen in rheumatic fever. But for high risk population, either polyarthritis or monoarthritis or polyarthralgia, any of these if they are present, then we take it as satisfying the arthritis criteria. Okay. So if any of these are present in the moderate to high risk population, we take this criteria of arthritis as positive. This is again an addition in the 2015 guidelines. Okay. So we said carditis, arthritis. What else? There is chorea or Sydenham's chorea is there. Okay. Chorea, which is also called Sydenham's chorea. Sydenham's chorea. Okay. What else? So there is something known as erythema marginatum. They are erythematous serpiginous rashes with a pale center and red periphery, and they can coalesce with each other also. So erythema marginatum is another criteria. And the last one is subcutaneous nodules, usually present over the bony prominences. Okay, subcutaneous nodules. Now, if someone asks you which is the most common clinical feature of rheumatic fever, acute rheumatic fever, then your answer is arthritis. Arthritis is the most common, seen in almost 75% of patients affected with rheumatic fever. The next common one is carditis, which is seen in 50 to 60% cases. 50 to 60% cases. Alright. Chorea is seen in 10 to 15% of cases. Erythema marginatum in around 1%, and subcutaneous nodules is the least common one, seen in less than 1% of the affected population. Okay. So these are the major 5 criteria in the modified Jones criteria. Carditis, clinical or subclinical. Arthritis, which is only polyarthritis in the low risk population. In high risk population, polyarthritis, monoarthritis, polyarthralgia, all of them come under the umbrella of arthritis. If any of that is there, we take it as arthritis positive. Chorea, which can be seen in 10 to 15% cases, erythema marginatum, erythematous rash with a pale center, and subcutaneous nodules. Okay. Now, what are the minor criteria in the modified Jones criteria? So, the minor criteria include joint involvement, that means polyarthralgia in the low risk population. Okay. While monoarthralgia, if it is present in the moderate to high risk population. Of course, in the absence of, if arthritis or arthralgia, if you have taken as the major criteria, you will not use this criteria as the minor criteria. Okay. So if that criteria is not present, only then you use this one. Okay. So in moderate to high risk population, even monoarthralgia you can use, right? Presence of fever is another criteria. Okay. Significant fever is another criteria. Then evidence of inflammation in the form of elevated ESR or CRP. Okay. And prolonged PR interval. If you have not taken carditis as the major criteria, only then you can use prolonged PR interval here. If you have already taken carditis as a major criteria there, then you cannot use the prolonged PR interval here as the minor criteria. Okay. Prolonged PR interval. So these four are the minor criteria. Alright. So polyarthralgia in low risk population, monoarthralgia in moderate to high risk population, fever, elevated ESR or CRP, and prolonged PR interval. Now there is an essential criteria. So essential criteria is that you have to demonstrate a recent evidence of streptococcal infection, which can be either a rapid antigen test from the throat positive, or it can be positivity of the ASO titer, anti-streptococcal, anti-streptolysin O antibody, or any of the other antibodies against, like anti-hyaluronidase antibody against streptococcus. So basically you have to give an evidence of antecedent group A streptococcus infection. So evidence of antecedent or recent group A streptococcus infection. Okay. Which can be a rapid antigen test in the throat positive, or it can be increased or rising ASO titer, anti-streptolysin O titer, or any other antibodies against streptococcus also, if you are able to demonstrate. Okay. Now, when do you call it that modified Jones criteria is positive? So, we diagnose rheumatic fever clinically. So, modified Jones criteria requires that, so in order to diagnose an initial episode of rheumatic fever, you need to demonstrate either two major criteria, okay, so either two major or one major plus two minor criteria, okay. If any of these is present, then we say that the child has rheumatic fever, acute rheumatic fever, okay. And for diagnosing a recurrence of rheumatic fever, the diagnosis is a little more liberal. So, we can demonstrate recurrence of rheumatic fever. We can diagnose recurrence of rheumatic fever in the presence of either two major or one major plus two minor, or even three minor criteria alone if they are present in the absence of any major criteria. Then also you can diagnose it as recurrence of rheumatic fever. So this is also a latest addition in the 2015 guidelines. Okay. So we saw in the 2015 guidelines, modified Jones criteria, what all has changed. One is that they have now classified them into low risk and moderate to high risk population based on the incidence of rheumatic fever and the RHD prevalence. Another important thing is that even subclinical carditis is now a part of the major criteria. Another important thing is in the arthritis group, in the high risk population, even polyarthralgia can be considered as a major criteria. And another important thing is that, for the diagnosis of recurrent rheumatic fever, even if no major criteria are present, three minor criteria alone are sufficient to diagnose it. So that is how you can diagnose rheumatic fever, and we saw that the most common manifestation is arthritis. So we said that the most common manifestation of rheumatic fever is arthritis, present in 75% of cases. Okay, it is migratory polyarthritis, usually involving the large joints, followed by carditis. And due to the carditis, the valves that are affected, the most common one to be affected is the mitral valve in rheumatic carditis. Okay, the mitral valve is the most common, followed by aortic valve, which is next common. Okay, so that is about the clinical manifestation and the diagnosis. Now moving on to the treatment and prophylaxis of rheumatic fever. So first, talking about the treatment of acute rheumatic fever. So, what is recommended is a course of antibiotics. A course of antibiotics to eradicate any group A streptococcus which is present in the throat. Okay. A course of antibiotics is recommended. So, 10 days of oral amoxicillin or penicillin is what is recommended. Oral amox or penicillin. Or you can even give a single dose of intramuscular benzathine penicillin or single dose of IM long-acting benzathine penicillin can also be given. And in those individuals who are allergic to penicillin or the penicillin group of drugs, you can use macrolide antibiotics like azithromycin. Okay. So, azithro in those who are allergic to penicillin. Okay. In penicillin allergic individuals. Apart from that, you are going to use aspirin. So, in most of the cases, we are going to use aspirin where we have established the diagnosis of rheumatic fever. Okay. So, we give it initially at a very high dose of 50 to 70 mg per kg per day, and gradually the dose is reduced. Okay. Right. Corticosteroids are to be given only in those cases where there is carditis is present along with, cardiomegaly or features of congestive cardiac failure. So, we give corticosteroids mainly in cases where there is carditis along with either congestive cardiac failure or cardiomegaly is documented. Alright. And in individuals with carditis, you will recommend bed rest. Okay. In individuals with carditis. So, that is the management of acute rheumatic fever. And once a valvular heart disease is established, you might have to do some surgical intervention as well. Alright. Now, talking about the prophylaxis of acute rheumatic fever or rheumatic heart disease. So, there is a primary prophylaxis and a secondary prophylaxis. Okay. So, primary prophylaxis. Primary prophylaxis means before it has begun. So, any streptococcal sore throat. So, any streptococcal pharyngitis should be ideally treated appropriately with antibiotics. Okay. Appropriate antibiotics should be started like amoxicillin. Okay. And it should be ideally started within 9 days of onset of sore throat to prevent acute rheumatic fever. Okay. So, this has also come as a question once. So, by when should the antibiotics, if started, they are effective to prevent rheumatic fever? So, adequate treatment of streptococcal pharyngitis can prevent acute rheumatic fever. Okay. So, any streptococcal pharyngitis, appropriate antibiotics should be started within 9 days of onset of illness. Okay. 9 days of onset of illness to prevent acute rheumatic fever or rheumatic heart disease. Okay. So, that is very important. Appropriate antibiotics there should be timely initiation. And it has been seen that, poverty and overcrowding, they are risk factors for rheumatic fever. So, if possible, you should, try to improve the general condition, the living conditions of people. Okay. Because poverty, overcrowding, inadequate treatment of sore throat, they are all risk factors for rheumatic fever. Right. So, that is why in developed countries, the incidence of rheumatic fever is quite low these days. Okay. So, that is about the primary prophylaxis. We also need to give a secondary prophylaxis for rheumatic fever. Secondary prophylaxis means in those individuals who have already been diagnosed as having rheumatic fever, we still need to give some prophylaxis. Okay. And why is it so? Because, repeated group A streptococcal infections, if they are there, they may predispose to recurrence of acute rheumatic fever. Okay, and they may, worsen the symptoms of the child, right? So, that is why a secondary prophylaxis is also required. Now, for secondary prophylaxis, what is usually used is injection benzathine penicillin again. Okay, so for this secondary prophylaxis, what is used is the long-acting injection benzathine penicillin. Okay, which can be given intramuscularly. Okay, so this injection benzathine penicillin is to be given in a dose of 6 lakh international units intramuscularly in children weighing less than equal to 27 kgs. While the dose is just double in children whose weight is more than 27 kgs or in adults, right? So it is 1.2 million international units IM in children with weight more than 27 kgs, right? So that is the dose of injection benzathine penicillin which should be given intramuscularly every 3 to 4 weeks in order to prevent recurrences and further worsening of the disease. So it is required to be given every 3 to 4 weeks. So till when the secondary prophylaxis is required? So that depends upon what was the initial extent of involvement. Okay. So if there was an acute rheumatic fever without carditis, okay, there was an acute rheumatic fever but without carditis, then the duration of prophylaxis should be at least 5 years or till 21 years of age, whichever is later. Okay. So at least 5 years or till 21 years age, whichever is later. That means if the individual is 10 years of age, you will give it till 21 years of age. But if an individual had the onset of rheumatic fever at 18 years of age, then you will give it till 18 plus 5, 23 years age. Okay. So till next 5 years or till 21 years age, whichever is later, you have to give it. Okay. If there has been carditis with carditis, but without any residual heart disease, that means no mitral stenosis or mitral regurgitation, no residual heart disease, but there was carditis at the initial attack. Okay. So with carditis, so if it is with carditis or without any residual heart disease, with carditis but without any residual heart disease, with carditis but without any residual heart disease, then you will give it for the next 10 years or till 21 years of age, whichever is later. Next 10 years or till 21 years age, whichever is later. Okay. But if the individual had carditis and residual heart disease is also there. Okay. So with residual heart disease, okay, then you will give prophylaxis till next 10 years or till 40 years of age, whichever is later. Okay. And remember, in individuals who are allergic to benzathine penicillin, you can use macrolide antibiotics. Macrolide antibiotics like azithromycin for secondary prophylaxis also, you can use them if the individuals are allergic to penicillin. You have to use alternate antibiotics. Okay. So so we saw the treatment, the primary prophylaxis, which is the treatment of, appropriate treatment of streptococcal pharyngitis and avoidance of overcrowding and poverty if possible. Secondary prophylaxis with benzathine penicillin every 3 to 4 weeks. If the individual had no carditis to begin with, you give the prophylaxis for the next 5 years or till 21 years of age, whichever is later. If there was carditis but no residual heart disease, you give it for 10 years or 21 years of age, whichever is later. With residual heart disease, you give it for next 10 years or till 40 years of age, whichever is later, right? So that is what you need to know from rheumatic heart disease in children, the most common acquired heart disease in children. Okay. So we have discussed in detail about the congenital heart diseases, the fetal circulation, which forms the basis of pathophysiology of congenital heart diseases, and an acquired heart disease, a very important one, rheumatic heart disease. Another acquired heart disease about which we have talked a little bit about in the immune system disorders, that is Kawasaki disease, where you can get coronary artery aneurysms. Okay. So these are the things that you need to know from pediatric cardiology. And of course, not to forget the image-based question, which you will see in the images section. So these are the things that you need to know about rheumatic heart disease. Okay, a very, very important acquired heart disease seen in children and across all age groups.